I would like to call in Toronto onto the panel Shivani and Zaina to join John, and Tony, if you could also join the podium. And here in Berlin, I would like Christian to come back to the podium, and our next guest, Kai Sachs. Okay. So. Wenn ich da sitzen darf. All right. If you could move the camera in Toronto a bit more to the left. Tony is left, sort of. Yeah. But we see, may I just introduce Shivani Goyal. Do you pronounce that right? Yes? From the Center for Global eHealth Innovation, and Dr. Zaina Kayat, Senior Advisor at Mars Excite. And here in Berlin, new to the podium, is Kai Sachs from SAP Healthcare Business Networks. Okay, are we all set? Can we start?
Yes, go ahead.
Okay, please make sure that your microphones are on. As I said, John, I'm going to take questions on your presentations once we are through with the round. Except there's a question from the audience, which would have to be answered right now. No? Okay. So we go ahead. The panel discussion we have now here will be on the technological developments and implications. And we had now two very good introductions, what that can mean. On one hand, treating diabetes as a chronic disease, combining all kinds of new techniques, and for a longer term established telemedicine. And I'm very happy for the new guests of the podium, and I'm going to make a little round now and make them introduced. And would like to start with Shivani from the Center for Global eHealth Innovation. Hello there.
Hi.
Hi.
Thanks for having me. Good morning, everyone in Toronto, and hi to everybody in Berlin.
Hello. I'm speaking to you now from your back. I don't know if you can see me, but I can see me behind you. Hi there. All right.
That works. That's okay.
That's okay, I hope. Right. For a start, please explain us what you do, and especially what the Center for Global eHealth Innovation stands for. Some of our Toronto friends will see the center later during the field trip, but please give us all an insight into your work.
Absolutely. So a little bit about myself to start. So I'm currently doing my PhD in biomedical engineering at University of Toronto with a focus on how to utilize health technology to improve chronic disease management. So that brought me to the Center for Global eHealth Innovation, which is located in Toronto General Hospital. So it's a non-for-profit organization with approximately 100 folks who come from varying backgrounds, focused on figuring out how to improve the use of technology for efficacious healthcare delivery. So these people include engineers, such as myself. We work with clinicians, software developers, and graphic designers to understand the fundamental needs of patients and healthcare providers and how to bring them into the conversation when developing technology. This brings us to one of our key points of focus, which is human factor. So our human factors group works with patients from the hospitals that surround us in Toronto. So there's 4 huge hospitals that surround us, giving us the ability to really be embedded in the clinical setting. So essentially, we bring these patients into our office, which is a huge usability lab. It's actually the largest usability lab in all of North America, and you'll see it later in the field trip. And essentially what this allows us to do is replicate clinical settings where we bring the patient into and try to gauge what's going wrong in the current healthcare delivery model. For example, when they're using IV pumps, where is the miscommunication occurring, and how can we capture that and then improve technology from that perspective? There's a vast breadth of work that we do, but coming back to the software applications, that's my particular focus, is trying to look at how can we use mobile phones and smartphone devices to improve long-term chronic disease management. And I'll cap it at that for the interest of time, but I'm happy to go into more depth depending on what comes up in the panel.
Thank you, Shivani. One first question from my side, to make it perhaps a little bit more illustrated. You personally work a lot on a project on prostate cancer. Could you describe us sort of what's happening in that project, sort of, if I may say, on the ground?
Absolutely. So actually, my focus is diabetes, and I'd love to give you a preview of that maybe in a bit. But the prostate cancer app is actually very novel and interesting. So we're working with Trillium Hospital here, who is struggling to keep track of their prostate cancer survivors. So essentially, these patients have gone through prostate cancer treatment and relapse due to a lack of tracking of their symptoms and being able to provide just-in-time treatment to them. So we created a mobile application that allows them to track their daily quality of life, symptoms, and most interestingly, pulls in their PSA lab results from the Ontario Information System. So what this means is, if a patient is going to a lab to get blood work done, we are now able to pull that lab result into the mobile application and show it to the patient so they have an understanding of how they're doing with their prostate cancer. And you can imagine for somebody going through this traumatic experience, that's quite powerful. When we also presented this and discussed this with patients, this was something they absolutely wanted. Now, as a clinician, you're probably wondering, oh my gosh, I don't want my patient seeing this result first. What if it freaks them out? Because, you know, they may not understand how to interpret it. So also there is a clinician app that first receives this PSA result, and then the clinician can look at this result in conjunction with how the patient's been doing over the last few months and what their quality of life is. And then they decide whether or not to forward that result to the patient or whether they need to engage in further education with the patient. So this is actually one of the first examples of us being able to pull in lab results from the provincial ecosystem, which is huge. And we've been working very thoroughly with the government trying to get this up and started. So where that project is currently is we're evaluating it in a clinical trial that will start shortly. So, you know, fundamentally behind all of this is the fact that we're growing on an existing evidence-based, and we are going to evaluate this to see what the outcomes will be moving forward.
Thank you. And that already illustrated very well how, what the impression I got from your work, also from your website, which is called The Human Factor, that you take very well in account the human factors involved in telemedicine, which is on the one side the patient and on the other side the doctor or the nurse. And last question for you before we go on to Zaina, who would you say is at the moment sort of more to be addressed, patients or medical staff to get used to e-health and the technologies involved with it?
That's a loaded question. It cannot occur without both sides. It really needs to be a joint venture. So starting with the clinician side, we see when we do surveys in Canada and abroad that clinicians are willing to use these type of technologies. They're just worried by the overwhelming amount of data that's coming in and what to do with it. There's questions around coverage, reimbursement, and accountability fundamentally for all this new sources of data that's coming in. So these are questions we're trying to answer, and I think we can learn from each other what to do in that particular area. From the patient perspective, which is very interesting to me, I am seeing patients of all ages being able to use the technology when it's well designed, ranging from kids that we work with at Sick Kids Hospital for diabetes up to older patients who are not mobile and have heart failure. So I think patients are ready and able to use the technology if they're in the right ecosystem that supports them.
Thank you very much. The topic of big data we will take up in a second when I talk to Kai. But before, I would like to welcome Zaina once again. And you're director of Mars Excite, and I'm happy you're here because for me you're a very essential part of the podium because you represent the whole new startup scene in the e-health sector. So could you just tell me what you do with Mars concerning e-health?
Hi, good morning, everybody. Hello to Germany. So yeah, I'm Zaina. I lead the Health System Innovation Platform at Mars Discovery District. Mars stands for Medical and Related Sciences, and it's an innovation hub really for Canada to help get us out of an industrial economy and into an innovation economy by harvesting a new set of assets called knowledge assets, and health is a big focus. And so we're enabling that to happen. As you said, a key part of what we do is building the next generation of companies that are going to solve the biggest problems of the world need solving and also drive our economy, and health is a big part of that. So we support about 300 startups, about 200 of them are in digital health, and we just do whatever we can to help them go from their idea to fix big problems to international scale. And so that's one big part of Mars. I don't actually lead that part. I used to, but I don't. So I'm happy to talk about that separately. Why startups? The work to be done to enable an e-healthy Canada or Germany is a massive, massive disruption of a fundamental paradigm and foundation of what our systems were designed for, which is a very physical, physician-mediated delivery of services. That is all ripe for being eliminated off the table and to people becoming the CEO of their own health. That's only going to happen with technology, and that's only going to happen, or the leaders of that are entrepreneurs. Entrepreneurs bust open the status quo. Incumbents, health systems, hospitals are not designed to self-annihilate. They're just not. That's Clay Christensen's theory. So that's why we focus on entrepreneurs, not just because it's sexy and fun. The other half of Mars, which is what I lead, is actually taking the platform and innovating at the level of the system. I just did a tweet, you could look at it, that says all these startups and all these tech, everything we're doing is completely playing at the margins of a fundamentally broken system. Our system was not designed to meet the needs of the society today. And so that's what I do, because if we don't fix the roots, the tree will die. And so I'll just highlight two things that we work on out of four at a system level that I think are relevant to this discussion. One is this program called Excite, Excellence in Clinical Innovation and Technology Evaluation, but basically we broker a process to help the Ontario health system proactively find and pull in very, very disruptive technologies, digital and otherwise. And unfortunately, I wish the system on its own would be innovative in learning and adapting, but it's not. And so we broker it through this program. And I can talk about that separately. We're scaling that now to Europe, United States, and Australia. And then the other thing I work on, and I'm reflecting on your prostate cancer, at a system level we're working on is, it is insane, honestly insane, and I literally, I use that word literally, that the person who has the biggest stake in their health can't get their own data. I fully disagree that anybody should decide whether or not they get their PSA lab results. It's my data. And until that information flows first, foremost, to and through me, the citizen who's paying for this health system, we will never, ever realize that e-healthy. We won't. We can do all the fun stuff we want. The data belongs to us. We decide who gets it. We have a major blockade of that data, so I don't know what goes on in Germany, but in Ontario, if I want to get my data, I need a really, really powerful fax machine. I need many hours to get those faxes, and I have to pay $10 a page. So until that changes, none of this will work. And so our most ambitious project is called My Health, and we're basically creating a gateway layer that connects citizens of Ontario to all of their formal medical data. We think when we build this gateway, the world's innovators will flock to Ontario to interoperate with that data, and we think we're going to unlock massive innovation. So I'll stop there. I'm not that passionate about this, as you could tell, but happy to keep having the discussion.
Oh, if you're so passionate about data, you should come to Germany. It's like it's one of our favorite topics, and I would like to ask you one question before we continue that topic with Kai. You just said disruptive industries and so on. We had last year the topic of startups and the startup scene in Toronto and in Berlin and how you can do it. And it was all sort of quite a few startups which would work outside of a regulated state system. How do you get a startup part of such a regulated system like health? I mean, I'm thinking of the German situation. Which product of a startup can be paid for by my regular health insurance and which is not, and who is deciding on that, leaving apart all the tests and so on before. What's the situation? How do you go along with the startups at Mars?
Yeah, it's just as bad here in Canada. Our startups are making incredible solutions. They're getting sales all over the world, but not in their own country. And so we do a lot of work on trying to help our system open up to access these technologies. Dr. Ed Brown just walked in the room. We're working with them on a project he'll talk about. So it's just as bad. And again, it's not the startup's fault. It's not really, the people who want the technology's fault. Our system was never designed for innovation. So you're going to get exactly the system you have. It's impenetrable. So that's what these other things I'm working on. So what they do instead is they kind of double, they have a double market model. So most of our digital health startups have a consumer offering or a private market offering, retail pharmacy, private insurance, et cetera. That gets them a customer base and frankly incredible data that they can then have a really strong evidence base and then come into the regulated formal medical system with a much stronger product and value proposition, and that seems to be working. It also is a nice way to bootstrap the startup because they can generate revenues in the private markets to fund the ability to do the much deeper research required to enter the formal medical system.
Thank you very much. I'm gonna introduce now Kai to the discussion. And then after his presentation, we will open up again the podium for questions and have a general discussion. So welcome, Kai. You are from SAP, and we had a prep talk this week, which was really enlightening for me, and I hope we can transfer that also here. Big data is a big topic for you also because you're coming from a company which is sort of familiarized with the topic from other fields. Listening to Zaina, what would you say are the big sort of challenges concerning big data and e-health?
So, yeah, first of all, thanks for the invitation here. And I'm really happy to talk to you about e-health. And I'm coming from a computer science background. So my background is in cloud computing and big data. So I'm less in medicine. So I'm focusing on healthcare since 1 year now. And I'm leading a team here in Innovation Center in Potsdam focusing on healthcare applications. And for us, the whole data story in e-health is quite challenging. So we see several problems here. I think we were at a field trip at Charité, and we saw that they have already 4 PB on data, and that are huge amounts of data which needs to be managed. And what we also can see that we have here a lot of different data sources which are in a lot of cases not very well integrated. So we have many sources, maybe even in one hospital and one which are not integrated to each other, so that when I go to a doctor, for example, a cardiology, we don't know anything about my previous stories in other departments. And for us, that is one of the key things we were currently working on. So we want to integrate the data of different sources and bring that together. I think we saw a very good example today at Charité, how this can work and how we can, also the patient and the doctor can really benefit by such a solution. However, this is currently not standard. So in Germany it's not standard, and I guess also the same in Canada. And the second thing is, if we now talk about this data, what we currently see is that we also get new technologies coming into place, and that is genomics data, omics data, which are also now flooding us with data. And I think what we currently saw until now is, compared to what will come, nothing in terms of data amount. So if you now look at next generation sequencing, we have machines who create for one sample 200 gigabyte raw data. That means if you have a healthy person, or you take a sample of a person and, for example, a tumor of this person, we have already 400 gigabyte raw data. And if you now think about your hard drive at home, if you go somewhere in a supermarket and you buy a hard drive, this hard drive has enough space to keep the samples of 2 persons. So there are some plans that each newborn child should be sequenced until 2020. And we can see really that we also need to, as a technology company, we really need to discuss how we can manage this amount of data and how we can integrate it into the normal treatment of our patients here. I think we already had a discussion that a lot of doctors are afraid of all the amount of data which is flooding into their practice. So we get all the tracking data, we get a lot of new sensor data, we get genomics data coming in there. And for us, we are really working on innovation technologies who can, let's say, help analyze this data and make it usable for a practice. And this is a huge challenge in the current moment, also in terms of big data and also maybe privacy and security. So.
Thank you. Another question to you before I would link back to Zainab on your project of My Data. As you explained to me there, the conversion of data is actually the big challenge which we have ahead of us. How, and Zainab, it would be great if you could comment on that, how, if I say, okay, I'm in control of my data, but I don't even know how many different doctors' offices, hospitals, and my fitness app, where they have the data and how I can draw it all together. So what would be your solution for that? And that's first to Kai and then to Zaina.
To be honest, I'm not really sure whether I have a solution for this. I think it's currently a big question. So a lot of people thought in the US everything will be better once the electronic medical record is introduced. So what we can see now in the market is that everybody has their own electronic medical record here. And yes, everybody talks about standards, but everybody is convinced that his standard is the best. So there's currently no exchange between systems, and what we can see here, and it's exactly the same here, but even if you know where your data is in place, you cannot really combine it currently, or you cannot bring it together. There's not a central point.
Thank you. Zaina?
So, that's the point of the My Health Data Gateway is exactly to solve for that, that you don't need one standard that everyone has to conform to. It just creates a way to convert data from any source into one channel to then be put into a different modality for the user to experience. So think about it like, I don't know, in Canada, if you go and put your bank card at the 7-Eleven, you've just now allowed them to go get data from somewhere else and do a transaction with you. That's basically what we're building. So you actually don't need to build all this interoperability and all these big enterprise infrastructure. It's just a layer of standards that link two worlds together. So, and this is happening in many other places in the world. So honestly, opening up the data and the convergence and all that stuff is about 5% of the problem. This is not a technically hard problem at all. It's complicated, but it's not technically that hard. And privacy, security, all that stuff, we've got solutions for that. The problem is changing behavior and a paradigm of thinking about what health is and who that data belongs to and what to do with it. On the other end, let's say we can beautifully connect all this data, convert it, and let me see it as the person with the biggest stake in this healthcare system. Pick any startup. They could prepare any tool, any dashboard you want to see whatever data you want. That is technically not a hard problem either. It's just when big formal health systems like hospitals decide they're going to get in the business of designing software and portals, and it's not their core capability, and they take years to do it, it becomes obsolete and not really relevant. Whereas kind of startups can do this stuff very nimbly and very quickly. You know, one of our startups, you could check them out. They're free. It's online, called Self-Care Catalysts. As a person who has multiple comorbidities, I could build any app I want to stream whatever data I want. So it's pretty easy to figure out. Again, the challenge is our mindset and our thinking about who's in charge of their own healthcare.
Thank you. And I would like to invite John and Christian back in the discussion, and anybody who would like to join in, raise your hand, give me a sign, and when you're in Toronto, tell Tony, and we will make sure you're part of the discussion. And actually, my next question would be to Christian and John. John, your work is going on since many, many years, and I would say you've left the startup status a long time ago. But still, when you started your business, what were your main sort of obstacles getting it installed? Was it more a problem of the patient using it or of the medical staff working with it? And also, one thing you didn't, or I didn't hear before, who's paying for your services? Because I was wondering, I'm a German on a Canadian boat doing this transatlantic trip. I fall off, and the whole thing, because in the end, I don't know what. Will my German insurance pay for that? Is this my private endeavor?
Great, good series of questions. So first of all, we did start 18 years ago, almost 19 years ago now, but I still consider us actually a startup in that we are changing, evolving, responding, trying to think outside the traditional boxes. So I hope that we're still in startup mode and probably will be for quite some time as the world around us changes. So, and again, because we're small, we are agile. And we want to try and do, so we're actually starting up with doing some direct consumer to doctor calls, which is an interesting experiment that I partially like and partially don't like. But I wanted to, and I will go back to some of your questions too. I just wanted to make a couple of comments about Zaina, because I like her passion, and I totally agree with every word she uttered. I think the technology needs to enable patients to have control over themselves. For too many years, probably several hundred years, we, the medical profession, have basically built up this opaque world around us. We've got this expertise. We've designed funding systems to make sure that you have to pay for my knowledge about your body. It is a bizarre relationship, and yet it seems to be completely part of what we do. So it's very troubling to many of my medical colleagues to be threatened by patients who actually know more about their data and have good questions from either Dr. Google or wherever they're getting it from. Some are more willing to have a conversation with patients. Others are still very threatened by that. So I think it's a fantastic disruption, as a gross technology that we need to definitely embrace. And I'm super keen on the increased transparency and empowerment to patients. What it means, though, is that we need to educate and give people competencies to understand the data as it becomes available to them. Otherwise, they're going to get a number and not know what it means. Another quick comment, too, just as there is a lot of data, and I'm afraid that the noise-to-signal ratio is getting worse and worse, in that we're getting so much data, we don't quite know what to do with it all. And I think some of those new technologies are solutions that are looking for a problem, and people are wowed by the flashing lights or by whatever it's doing, and are willing to invest, but they don't actually ask the question, so how does this actually make a difference? Does this matter? What's its impact? And I'm worried about money being spent on things where it's really not going to be particularly useful. So I think Mars is probably doing a great job in helping us to try and figure out what's of value, where should we be, what should we be filtering out, and so we can focus on some really important questions and try and come up with some solutions. Praxis, if you fall off the boat and you're a German on a Canadian boat or on a UK boat in this case, it's really a different funding mechanisms. In many of the cases that we do, We are like an insurance company, a company, a shipping company, or a yacht owner, or an insurance company will pay us a daily rate to be available. And so again, because we're 24/7, we don't do very many fee-for-service type calls. It's usually you pay a very small amount for us to be available to you anytime. And so where you're from and whether you have money in your pocket doesn't really matter. You've kind of paid up front or you're paying continuously. The more people that are on board, I guess the less it is. And as I said, it really just, it's a series of different funding arrangements depending on who the client is and what their expectations are, is how it works. And to be honest, I mean, I look at what we cost. We're not making a lot of money in this business so far. I mean, most of us are doing it because it's fun, it's interesting, it's entrepreneurial, it's very different than what we normally do. So I think that hopefully answers part of your question anyway.
It does. Thank you. Tony, you tell me when there are questions from the audience in Toronto. Any questions at that moment from the Berlin audience?
Yes, we have. Oh, okay, go ahead, Alex. We have one question here, though, after that. Yes, I'll hand over to you then.
Hi, I had a question for Dr. Ross, John. I was curious about the patient record. So if someone falls off the boat and you do some care for them and you fill out the patient record and then they're flown somewhere, Quebec, Ontario, BC, does the patient record follow them and then consequently gets transferred to their system where they're treated?
Great question, thank you. So the online medical record is completed by the physician for every call we do. Depending on the setup prior to this arrangement starting, we're stuck with fax at this point, because most hospitals still have faxes. They don't have access to related things. They don't have an email account or something they can go on, which is again ridiculous. Don't get me started on that whole topic. But anyway, so we're stuck with usually faxes. So once I push submit, I've completed the story, I've done the physical examination, I've done the recommendations. We can actually prescribe medications through our device too, so it'll have a drop-down menu. I'm going to say take 2 of these ibuprofen 3 times a day, an antibiotic potentially, and then I push the button and it will then log that data on it. And then depending on the relationship with the caller, once I push the submit button, it automatically sends a fax with that sort of salient parts of that record to the caller, to wherever this client wants us to send it. So we're not going to send patient data to the employer, for instance, because that's obviously a breach of confidentiality. But if a medical provider at, say, the hospital as you're talking about, you get medevaced from a remote site to a receiving hospital, they will get a copy of our records, so they know what was the interaction, what were we thinking, here's how we started to treat the person, here's what to expect when this person does arrive at your site. So I think it's it's providing data and information to try and improve the quality of the care of the patient. And then that ideally would then become some part of a medical record so that they know prior to arrival what's happened, what the story was, and what I was hearing. And maybe it might be that the story I obtained in the rigors of this phone call is not quite as accurate as what they can get in the quiet of their hospital too. So it sort of gives them a sense of where this all evolved.
Thank you.
I'll just further add, all the records are then, they're kept in our secure system forever. So we can search that, we can go and draw it up. If there's, touch wood, so far we've not had any legal issues, but if that ever came up, that would be something we would be able to draw upon. And the patient can always have access to the record.
Hi, everyone. My question is from Zaina. So, first of all, I share the passion with you with respect to access to the patient data, and I try to convey that passion to my students, so to encourage them to push for this. My question is about your My Health project. So how do you compare this with the an earlier attempt in United States, the blue button attempt that started actually in 2010. So how successful was that initiative, and how do you compare that then?
Yeah, so our version of the blue button is My Health. So we're working very closely with Washington on making sure the standards all comply and learning the best of what they've done. So we're part of a global team with Estonia, Netherlands, and Australia and the United States. So we all learn from each other. So I don't have a comment on the success of Blue Button. I think they've gotten pretty good reach. Just remember, the blue button in the U.S., which is the idea would be if I'm a citizen, I can push a blue button and get my data from wherever it sits. That's the idea. The genesis of that was military personnel coming back from Iraq who used to be in one medical system, and then as soon as you become a vet, you're now in the VA medical system, and the data wasn't transferring. That's why they started that process. We don't have that issue of portability as much, so it's not the business driver. For My Health, the business driver is this. Anyone want to guess how many hours a year somebody with a chronic disease spends managing their illness? Throw a number. 6,000. Okay? And 80% of the demand of our whole health system is chronic, and it's only going to go up. So, of course, if you have a tumor in your brain or you just got shot, you need an acute care system. There's no question. And I'm all for that being digital, but that's not going to make a big dent in the opportunity and the problem. So 6,000 hours. Guess how many of those 6,000 are spent with our formal medical system? 10 hours. So all of our efforts, our noise, our conferences is on these 10 hours of professional time. And there's 5,890 that is me in my house managing my disease. That's the massive, massive opportunity for digital health, I'd say. We can do really fun stuff for digitizing the formal medical system. I think it's going to be diminishing returns without tackling the 6,000 hours.
Thank you, and that brings us back to the diabetes topic, and I would like Christian and Shivani to talk a little bit about how you experience like getting on the market with your product, who's mainly supporting you, is it the patients? And that was a very impressive number, spending 5,990 hours a year on your disease. Is it the patients? Is it really sort of the healthcare system trying to cut costs? Or is it industry pushing onto a market with new products? If I may, I'm gonna ask first Christian and then you, Shivani, from your Canadian perspective, okay?
Thank you for that very interesting question. The first support that we got was from a health insurer. So I showed you the trial that was sponsored by the health insurer because they saw that they spend too much money on those patients with diabetes. So they wanted to see if this approach of telemedicine can help, and we showed, yes, we can. On the opposite, talking to other health insurers is important, but it's not so easy because they want to see the cost reductions this year and not the cost reductions in 5 or 10 years. So this is a hard way to go. And in fact, it took us almost 2 years to get reimbursement from all the health insurers. So the German health insurance are a bit hard to talk to.
And who would you talk to when you plan now to go to Canada?
Going to Canada is easier than going to the US, since we don't need this FDA. Once we have CE mark, there is an easier and a faster process to go to Canada. And in fact, we will start this process in January next year. So I'm very happy to be here today to see there is also a need in Canada and that we have a solution that will help your patients over there.
All right, Shivani, I would hand over to you.
That's a really interesting point that Christian brings up about the return on investment for diabetes solution is not immediate. And that tends to be a challenge when getting governments and local bodies to adopt some of the great solutions that we know work based on a lot of our research. So now, based on this aha moment that I think we're having, we're turning, at least from a public perspective. So innovators like us who are from the public seat are turning to some of our private sector partners, looking at a consumer strategy on how to access people who may not be interacting day to day with the healthcare system, but are actually just going to their Walmart or their pharmacy looking for solutions and empowering them from that perspective. So it's a very exciting opportunity, and I think is going to bring us to the market quicker and in a more effective way.
All right, and Kai, I'm just one more question
We
from
have
my
one-
side, Tony, and to finish that point.
We have, okay, go ahead.
Okay, Kai, because you're representing SAP, a big private player, and I wouldn't say that at the funding of SAP, you probably thought of being big in the health market. Now, you told me a lot of your colleagues and so on, you really love the idea that you're part of the healing process, if I may say. What will be for your company like the long-term vision of working in that market, meeting products like the one from Kirsten or the work from Shivani or any startup from Sena?
Yes, of course. The vision is to build technologies who are helping startups or other products or healthcare providers in enabling such technologies. For example, we have an health engagement platform which should enable diabetes apps, for example, which we do with a life science partner. We have also a platform, a foundation platform, which should allow integrating different data sources. However, we are not in the service business. That's not our core competence. So that's something that our partners or customers can do, and we are helping them here to enable them. And what I can see is that we have, for example, in the domain of oncology, several projects, and also for people who are coming only from software engineering background, it makes a difference whether you work, for example, on a new accounting system or on a system which can help treating cancer. And even if it's only a bit, the people are very passionate about that. So what's something what we can really observe, and if you come to our teams, you will see a lot of people, I think it's also in your teams this way, that the people want to work on the topic, so we decide to go there for the topic and not for technology, at least in our team.
Thank you. Back to you, Tony.
I'm just going to take a quick moment. I'm going to sound like a ranting crazy man potentially, and maybe I am anyway. But we're using the expression healthcare a lot, and I just wanted to point out for the audience that really most of what we're talking about right now is reactive disease care. Someone's got a problem, diabetes. I'll use diabetes as an example in a second. But you have something wrong, and then we have to try and fix it. And trying to fix something is never quite as good as not being ill or damaged in the first place. So diabetes is a great example of, I think, where technology really has two very divergent roles. One is in improving our reaction to the disease process and trying to monitor it better and manage it better. But the other part of technology is encouraging people to not get diabetes in the first place. And that may be through, again, regular moving your body, having better advice around diets and sort of things. So that to me is healthcare, is maintaining your health, caring about your health. And we tend to not think about that because the healthcare system, as we all know it, is this big monolithic hospital and doctors and CT scans and blood tests. So again, I think being able to kind of keep those split in your mind and ask yourself, is this truly healthcare? Can we spend some more money on truly preventing diseases, keeping our people healthier and more productive, and then also then be able to respond to people who do get sick or injured and be able to get them back in the game quickly. I think that's the role of our healthcare system.
Yeah, so just to add to that, if you read the Globe and Mail, which is our national newspaper this week, they profile one of our startups that's squarely in the wellness space named League. And the title of the article is Our Health and Wellness Benefits the New Pension. And so employers used to count on insurance companies to do these interesting things called processing drug claims, and that was supposed to be health benefits. They're now getting really deep in innovation to keep their population and their workforce well. 40% of disability is mental illness in the workplace, just as one example, let alone diabetes. So to a point where there's a prediction that by 2030, healthcare will be free, because it's going to be so vital for you to be participating in the workforce, because only when you're working are you paying taxes that allows society to prosper, that the employer will have to pay for all of your care as part of just being an employee, not this like weird benefit thing on the side. So it's becoming clear because, like you said, our formal sick system is designed for when you're not well, but there isn't really a place to invest in wellness that's concentrated. It's distributed in things like our education system, our water supply, our environmental factors, et cetera. And so the private markets, I think, is going to take it into their own hands. They're going to have to, or else we won't be able to actually have functioning jobs in society.
Question here from the audience.
When you ask a question, please say your name and your affiliation. Thank you.
I'm Naveed Nazir, working for Limasonics at the moment. But my question is generally directed to the panel. If I'm collecting my data through Fitbit or Apple Watch, how trustworthy is that considered by physicians? Because my impression is they discount that. They think it is fluff.
Who would like to answer?
Yeah, so I can maybe start that conversation. So I think the way things are currently laid out with commercial products, there's a misunderstanding in the communication when a patient comes into the clinic and is presenting this information in its raw format. I think that's when it gets discounted. But if we can introduce that information that you're collecting in the grander scheme of your health and provide an overall context snapshot of what that actually means for your health, I think clinicians will start to take that more seriously. So an example of that is if we're able to show at your 6-month appointment, overall, you've been sedentary, you're hypertensive, and you've gained a couple pounds, that provides a picture that can actually enable informed decision-making when you're in the clinic. And I think that's where we're starting to move. And we've actually sat at the table with Apple discussing HealthKit and all these great technologies, and they're at the standpoint that we are giving you the tools to do it. It's up to organizations like ours to figure out how to make that an effective communication tool for clinical management. So I'll start there.
I'll quickly just wade in briefly as the doctor here. I think there's one more doctor in the room. But we don't, as of November 20th, 2015, I don't think that the vast majority of us have the competencies to know what to do with that. We haven't been trained. It doesn't fit my paradigm. I'm not actually paid to get data from you. Thank you very much. I'm going to get it from a blood test that I order, or I'm going to do it my way. It's I tend to be. I don't tend to be, but many of my colleagues. It's a paternalistic system, and I think that there is the question of how reliable is it? What's the pickup rate? I mean, I think that's still to be determined a little bit, but we just haven't incorporated it into our routine business. And I'm not. The system, as Zana's already said, is not designed currently to encourage me to care about your data, and it should be.
I have the impression Kai would like to add something.
Yeah, so I think we're the first prototypes in that direction where you can see where we can integrate this data. For example, we have with Stanford Medical School a project ongoing where we integrate Apple healthcare data into a panel including the genomics data, so that we also bring together data from different sources. So it's not only the healthcare data from Apple, or let's say the movement or the heart rate, but also including all the clinical history of the patient. And then it gives, I think, a lot of value for the treatment and for the diagnosis for the medical, because I think it's a new way a new data point, but you need to see it in correlation to all the existing data.
Anybody would like to respond? Okay, Tony,
We have
I
one
would
more
like
question
to...
here. Yeah, we have one more question here from Toronto. I'm going to pass on to you.
Okay.
My name is Vicky. I'm a postdoctoral student at the University of Toronto. My question is for Dr. Cray and Shivani. So from the perspective of maybe a diabetic patient who uses an insulin pen, so you've got, you take your blood glucose measurements, and then you also have to look at your calorie count for the food you're eating, and then maybe you go out with some friends, or you're looking at what you're eating there, and then you might want to factor in exercise, and maybe your blood glucose measurements fluctuate because of what you're doing or what you're eating, whereas most of the devices for blood glucose monitoring are just to take your blood sample at a specific moment in time. So the patient is kind of responsible for managing what they're eating, what they're doing, what they're exercising, and then you might have your machine for blood glucose, you might have your machine for calorie counting, and then you have some other documents where you note what you're eating or what you're exercising, like your Fitbit, and then you're like stuck with all these different technologies, and you have to maintain all these technologies. So I'm just curious as to, with the smartphone system or the different apps, are you thinking about integrating all these different types of things for the diabetic patient, including calorie counting and exercising and things like that?
May I start? Thank you for that question. Yes, indeed, we are currently programming these kind of downloadable other devices. So, like Fitbit, for example, like other exercise. Our current blood glucose meter is able to get input for the carbohydrate you want to eat. So there is the opportunity or the possibility to also have an entry of carbohydrates you want to eat. And the basic question, or the answer that I have is, of course, we don't want to focus people with diabetes only on their glucose levels, because there is much more. People with type 2, for example, we have to measure their blood pressure and their cholesterol, for example. So there is much more from a diabetic point of view to get the data, and the more data the patient as well as the physician has, the exacter or the more benefit there will be the therapy.
Okay.
To add to that, if I may, quickly, I think you've asked a very interesting question that I could talk about for hours, but I will say that the long-term vision is we have technologies that allow people to easily capture all of these behaviors, and then we're using the phone to, without burden, in the background, provide insights when it matters, so that when you are going out to eat, we can remind you, hey, you know, last time you came to this particular location, you tended to be hyperglycemic afterwards. So at a more concrete level, we are doing this currently. So one of our mobile applications, Bant, allows you to pull in your Fitbit data, take photos of your meal, wirelessly pull in your blood glucose reading, and gives you a snapshot saying, hey, when you're sedentary after your dinners, it tends to be really bad for you. And we're processing that data using algorithms to give insight, taking away that burden from you having to sit there with this massive log sheet trying to draw relationships onto how to manage your chronic illness. There's a lot of work to be done in this space in terms of interoperability. You know, I'm sure Emperor has much to say on this topic, but there is a lot of burden associated with these various devices. You're right to say that. But I think we're headed in the right direction as to how to handle the data coming from those devices and processing it in an effective way.
We have one quick comment from Dr. Ross.
Like chatty Kathy here. I just wanted to caution us all, and again, I'm just going to sound like maybe a bit of a wet blanket, but I think we have to be mindful of the people who are out there who are getting diabetes. May not be, I'm looking around the room here, it's a pretty healthy looking group. Likelihood of diabetes relatively small. Rural Canada, and people who don't have smartphones and all those sort of things, we have to think about how do we get them involved and give them the competencies to use those gizmos so that they're comfortable and actually motivated to do it. So I think there's some change management to keep in mind.
And I'll just add, most people who have diabetes have other illnesses, so I have a real problem with point solutions, even if they're integrated. They could have COPD, they could have kidney failure, usually mental illness. So it's designing for my life, not for each component of my illness.
Christian is
From
really
this side, so over to you.
thank you. Christian is really getting excited here on the podium, but I said before, we can't go into details of every aspect, but I would like, Tony, I would like to make sure that everybody who's interested into Christian's work gets the address, or that you make contacts over there. And me, myself, I would have many questions to go on with this podium now, but this is also a networking conference, and I want to give everybody the possibility to have a coffee, talk to the person he's interested to. I want to thank both my podiums here in Berlin, Kai and Christian, and in Toronto, John, Shivani, and Zaina, for a very interesting discussion. I'm really sorry we have to stop now because I've prepared for this conference over the last 2 weeks, and I get the impression I speak now your language, but still we have to stop talking. And I see you back here, let's say 5:05, which is 11:05 in Toronto. And then we will talk about more all these brand new technologies and so on, what it means politically and how we can regulate that. I want to thank you all very much and see you back in 25 minutes.
Thank you.